Hey, Texas.
Hi, how are you?
Did we meet before? Or?
I don't
know. I'm with Biomax, the fetal tissue collection agency.
No, we haven't. I'm Ann Schutt-Aine. I'm her medical director at Gulf Coast at Center for Choice.
Oh, you are? Like the medical director for second tries, I guess.
Well, so Paul Fine is the medical director for the entire affiliate, and I am over the abortion services.
Oh, okay.
Last night.
Okay.
Two providers that goes up to the state max. So if there's going to be, like, you know how I was telling you Thursday, Friday, Saturdays are heavier G&E days? Oh, yes. She's one of the providers.
Yeah.
Oh, and no, it's fine.
No, it said to me that that you guys had a great conversation last night about how he's, you know, for him to go out there, and there was talk of the quality of specimens and all kinds of things. Like, you'll be so excited, like they're really down. They want to. I'm like, well, that's what we found out when we went there. So
yeah. No, it's good. I mean, we definitely have the volume. So.
And the quality too. You know how to do some of the tricky, like.
Yeah, and we do our best. I mean, especially when it, you know, sometimes it's not possible. Sometimes, but you know, we had a patient a couple months ago who it was an anomalous fetus, a desired pregnancy, and she wanted footprints. And so I made sure that the resident didn't do that procedure, so that I was able to do it in such a way that we were able to, you know, get footprints in here. So
yeah.
You know, it's not always possible, but we can, you know.
No, so we're not looking for footprints and handprints.
No.
We're looking for livers and cardiac and those. Yeah.
Those I can get you without much difficulty at all. Yeah.
Good. Do you do the whole convert to breech beforehand? Were you trained by Deb?
No. It depends. It really depends. But you know, even without that, we have the capability to get this.
And what is it when, is it just like you're more careful, or how do you, because I know different people.
I think a lot of it has to do with dilation. Really and truly, a lot of it has to do with dilation, because when you have good dilation, a cervix that's either well dilated and or just softer and more pliable, then as you bring the fetus down, you can get more of it out before disarticulation occurs.
Right.
And you can get bigger pieces out before disarticulation occurs. Whereas if you don't have good dilation, then you're literally almost like, you know, because then you're picking, because you know, you get whatever's in your forceps. But if you have good dilation, then more than that will come past. If you don't have good dilation, then all you're getting out is what's in your forceps.
It just gets stuck right there, and it just
whatever's in your forceps and nothing more.
And those forceps, they're made to grasp, really. So if something's going to give, forceps aren't going to give. It's the rest of it. Right.
And you know, there are some centers who do a lot of same-day preparation, even for up to 18, 20 weeks. And you just don't necessarily, not that you cannot do the procedure safely and effectively, but the dilation is not necessarily important.
But you guys dilate day one, and then on day two you do the procedure.
Correct. And even for patients over 20 weeks who need more dilation, we still do it essentially in one day, because we do Dilapan 3 to 4 hours in the morning, take those out, put their second set of overnight dilators in, and then have them come back in.
So you guys are all Dilapan?
No. So typically we use Dilapan for one-day procedures. So usually between like 15 and 16 weeks, they'll get Dilapan and do it in one day. And then over 20 weeks, we'll have them come in, we'll do Dilapan for about 4 hours, switch those out and do overnight laminaria. So they're still getting 2-stage dilation, but it's not taking 2 days to get it done, or 3 days rather to get it done.
Are you ever using MISO for dilation or no?
We typically use that under 15 weeks. But we haven't been using it a lot in combination. Sometimes, but not a lot. And we use it, and we don't tend to use it at higher gestational ages alone.
Makes sense. I mean, do you agree with the move, like the switch to do things in one day, or where do you come down on that?
I worry about future cervical patency.
About what?
Future cervical patency. We do have some data that suggests that in terms of risk of future preterm deliveries, women who have had laminaria, have overnight laminaria, have less risk than women who have other dilation methods. And it makes sense from a biological plausibility standpoint. You can imagine that slower dilation over time, overnight, puts less kind of force on the cervix and is perhaps less likely to cause, micro damage than if you are, doing misoprostol for a few hours and then doing mechanical dilation to do it in one day.
Right.
So we don't have great data on that, but there is some thought that the overnight dilation may actually be, and so that's what one, that, and then two, it's just, I understand that everything else being equal, women would rather have the procedure in one day, and especially in Texas when you have a requirement for coming 24 hours beforehand anyway. I realize from that standpoint it can be difficult, but from a safety perspective, from a lot of, Thursday, Friday, Saturdays are busy days for us with D&E. It's not uncommon to have, 4 to 6 second try procedures along with, 25, 30 first try procedures on a Thursday, Friday, or Saturday. And so if my D&E are even taking, 10 minutes longer each, by the end of the day, it's an extra hour, on my clinic day, because I don't have as good dilation.
Right. And that's if you're trying to do one day?
If you just don't get as good dilation.
So it ends up, in terms of the clinic flow and time for the clinic, you think it might actually not make that much of a difference because it's...
No, I think it's actually better to do overnight dilation. Because you get better dilation, and so your procedures
are smoother.
Right. Now you can't do them safely and effectively.
Right.
But there's certainly, I would much rather do 3 or 4 passes than 15.
Right. Is that your average, like 3 to 4 passes to remove everything, or? Yeah. Tram's listening in. She's like, you take notes on it. You keep track of it. Yeah. Oh, you probably do actually. Yeah.
It depends. There are some that are like, I need you to make one more pass. Like avoid PBA. Yeah. I'm like,
to avoid the federal law.
Too close. I was like.
Oh, wait, so you're sitting there like coaching her, like watching how to...
No, but we know, right? Like if I'm doing a procedure and I'm in fear that it's about to come to the umbilicus, I might ask for a second set of forceps, hold the body at the cervix and pull off the leg.
Oh, so you get okay.
So it's not...
Right.
Yeah.
So that's where if you've got it coming out to umbilicus and that torso area is also intact, that's when I start to get excited because that's all the organs in there that were right there.
I find that even if I can't get it out intact, I can still get you a good sample.
Now, if you just do a disarticulation though, while sitting, so you'll pop a leg off or whatever, then you're free, right? Like it counts, and so then you can just bring the rest of it through all in one piece because you've already done a disarticulation.
Correct.
Yeah.
And usually at that point,
And obviously, and you probably do the whole intent statement thing and all of that with the ones. Do you think that's better than Dig, or what do you? Because some people, that's another controversy.
I have zero experience with Dig.
Oh, really?
I've just, I just don't have any experience with it, so I can't really speak to that.
Yeah. It nukes the stem cells, obviously, so we don't want anything that's
Right.
I had a colleague who tried to do a cell isolation on a liver that was from a fetus that had been diged, just for kicks and giggles to see it. Oh, excuse me.
How does that make you?
Oh, yeah. Just to see if they could get anything out of it. Nothing. It was all completely dead. Nothing. Yeah, of course, right?
Right.
So it's a thing.
Yeah.
It's a real thing.
So like I said, even in the procedures where I'm not doing anything close to intact, I find that it's pretty easy to, identify and isolate relatively intact abdominal contents.
See, and I told you that the abdominal stuff is the easiest.
Yeah.
Hands down. But the thymus, I don't know about all that.
The thymus is going to be a little bit trickier.
Right, because it's right up here. it's smaller. And that's the thing is, even if they're all intact, if it's all spilled out of the body, by the time you've got it all there in the tray, it's kind of like you're spending like an hour playing Find the Finest, like hoping it's not
kidneys, lungs.
Yeah, we saw all that. Yeah.
It was like a 16-weeker that Dr. B did, but it was on a minor. And so it was one of those minors where like Dr. B had to like hurry it up and like.
Yeah. Was it because the patient was not cooperative?
Yeah.
Or okay.
So it was just like not the smoothest, but like when you have patients who like cooperate, sometimes it just like, and there's good dilation, it's just like one pass and
you get the whole thing.
The matter is that as in our kind of medium range planning is getting a nurse anesthetist or somebody who can do deep sedation like propofol or something like that. Because one of the limiting factors in doing an intact procedure. So Beasley, the other one who does a lot of the bigger procedures, trained at Columbia, and she was trained to do intact procedures without DINs. So what their practice was is they would deliver to just above the umbilicus, but then you can reach down and bring down the cord, sever the cord, wait for pulsations to stop on the cord, and then you can do an intact procedure. So, but to do an intact procedure, you are doing more manipulation intrauterine, so you need patients to be more comfortable.
Right, because if they,
And so, the level of manipulation that's often required to do an intact procedure and the level of dilation, we just don't have the sedation capabilities to do. So, in a couple of years, hopefully we'll be able to have a nurse anesthetist or somebody who can do deep sedation, and then we can do more intact procedures.
There you go. Well, I think Misty is supposed to be sending us some stuff pretty soon, so...
Yeah, we needed to, her and I needed to meet with legal, just because we're in Texas, we just always want to be like, so we're just meeting with our legal counsel, and then setting up.
Did you hear anything about the stuff with Greater Texas and what their, confusion is?
I have no idea.
No idea.
Trust me, because I would never have had a conversation with you if I wasn't already fairly confident that it was going to be, that our rates were covered and stuff like that.
No. It's and I saw the provider who I know, Anna Dermesh. I saw her walking around the hotel a couple days ago. Haven't seen her since. Do you know Anna?
I met her. She had to go back to work, so she left yesterday.
Oh, that's too bad. I was hoping to. We met at the SFP meeting back in October, and just told me about the IUD research she was doing and all kinds of stuff. And it was cool.
But for some reason, so PPGC said that it was illegal, correct me if I'm wrong, pretty much illegal to do this kind of
they didn't. They said it was not allowed for whatever. And I said, well, is that like a statute? I was like, I know there are researchers in Texas publishing their research using aborted fetal tissue. There's no way it can be completely illegal. But apparently her CEO was very, very uncomfortable with it and said, no.
I'm all like, okay.
I mean, you guys have done it before. You've been doing it for a long time, so.
And so I was excited. I was like, we've been wanting to do it.
And it's surprising, a lot of our patients actually ask, because I think in our standard kind of consent form it says, sometimes they're research, and sometimes I'll have patients ask, is this going to be donated to research? Because they want something good for humanity to come out of it.
I think that's really important. And it's one of those things we were talking with one of the other procurement companies last night about some of the issues just with the whole stigma and stuff like that. There's these areas that people are just not really comfortable talking about, even in our own communities sometimes, and that holds everybody back, and it ends up kind of coming back to bite us, a little bit later on, because then. So.
I mean, I think a lot of the work that's going on in terms of destigmatizing, normalizing, I think it's hugely important. Were you at the lunch today? So there's this young woman, fourth-year medical student, who got an award for her work, and she's just, she is full of ideas and enthusiastic and ready to go, and she's like, we need to make this move. We need to partner with companies like Nike and Job and Banana Republic, and she's like, I don't know how you partner to make moms wearing Gap jeans instead of mom jeans. I'm like, yeah, I'm a mom. Yeah, I had an abortion.
Yeah,
right? Like,
yeah, and you know,
and I wear Gap.
Yeah, and you were probably in the plenary earlier today, right? I don't know if I was hearing that from the older ladies up on the stage. I mean, a little bit. I don't know. What do you?
I think they're very interested in reducing stigma, but I do think that some of the older people, I think in particular, and I'll say this, I think particular from the Planned Parenthood side, are a little more conservative, right? And a little bit more, trying to be a little bit more measured in their responses. And while I can understand that, I think sometimes, you know, like it's been 40 fucking years.
Yeah.
We can't be measured anymore.
Right. Right. I mean, and the interesting thing, you know, I talked to Dr. Collins at the Medical Director Council a couple of, like 2 months ago when we were there. And she said that stigma reduction is is a major goal for PPFA communications now, though, which is kind of a big shift from even just a couple of years ago.
Well, and I think part of what happened was, you know, she mentioned this morning, and she kind of got on Planned Parenthood rightfully for the whole issue around the Coleman thing, right? When they were like, well, abortion is only 3% of what we do, 97%. Which is true, but there's a way of saying that without throwing abortion under the bus. And I think that PPFA heard that a lot from their abortion providers. A year ago, there was a second tribe providers meeting that PPFA convened. And, you know, one of the things they were like, you know, at the end of the meeting, like, what else do you need from us? What else do you... And the providers were like, stop talking about it as only, you know, like...
Yeah, as if you were ashamed of us, right? Yeah.
We're not your dirty little secret.
Yeah.
How about we take such good care of women and men, and we do such a good job of getting them contraception that we have that abortion services are a smaller part of what we do because we take such good care of them, but it's still a necessary service and we probably offer it. Right? Like there's a different way to message it. And I think that they heard a lot internally that we were pissed that they kind of, so we felt like we were being thrown under the bus.
So like after that they did an abortion thing with University of Michigan, and they actually like called us on the phone and was like, you know, what do you say? And like when I was interviewed, it was like, I feel more stigma internally than I do externally.
Wow.
And that was like my straight up like.
Wow.
And we're lucky as an affiliate because we have a CEO who is very supportive of our abortion mission, and not everybody's CEO is. And so I think that's part of the reason why they've latched onto this destigmatization movement that's going on, is because they realize that their own providers are pissed at them. They're contributing potentially to that.
Wow. That's inspiring. There's a little rebellion in the ranks that actually changed a little bit of the direction.
Right? I think one thing you learn from this meeting, as opposed to some other family planning meeting, is how passionate abortion providers are about what we do. Right? And we are careful about talking about what we do because it can be dangerous, but we're not ashamed of what we do. And nobody puts baby in the corner, right? Don't you put it in the corner. That's all I think. Don't you put your baby in the corner, right? Because we're not having it.
That's good.
We're not having it.
That's good. That's incredible. Well, it sounds like, I mean, from an outside perspective, like the past 2 or 3 years, I've seen the shift. Like we've seen it, so it made a difference. Sounds like it made a big impact.
And I think I think it said a lot to abortion providers within PPFA when Cecile came out. And talked about.
I was very surprised because I remember reading in the blogs just a couple years ago, people complaining that Cecile Richards isn't saying anything. She won't talk about this one subject. And then I saw that headline. I was like, really?
And I think it's great every time that I hear about another female legislature or somebody who comes out and is like, yes, I had an abortion.
Contact theory. Right?
Well, I mean, when you look at the statistics, how many women in this room, given the statistics, have had an abortion? A hell of a lot. A hell of a lot. And those of us who haven't, it's probably more than luck. lot of other things. Thank you. She's looking out for me, finding me shrimp.
That's crazy.
You could just leave the plate here. I know, actually, that would be all right.
Wow.
Thank you. You're welcome. Thank you. More than welcome. Enjoy, guys. Thank you.
So how long have you been a provider?
Since my 4th year of residency, when I was trained, which was in 04, and I've been providing at least part-time since then. So when I finished my residency and for the first 3 years thereafter, I would do 1 to 2 Saturdays a month at Planned Parenthood in Pittsburgh. And then I did a year full-time as an associate medical director in California, and that's the only thing I did was I did Planned Parenthood work, including 2 to 3 abortion clinics a week. And for the past 7 years, I've been here where I split my time between Academic Medical Center and Planned Parenthood.
Oh, okay. Which affiliate in California?
Golden Gate, before it was dismembered and became something else.
Where was that?
San Francisco.
Okay.
Within the Pacific. It's not like Monte and Shasta.
Yeah, we're from Southern California. Oh, okay.